distributed in communities characterized by inadequate access to water and sanitation services, and these are factors which have been associated with cholera outbreaks. Some cases might have been missed though, due to the low index of suspicion by healthcare workers and poor health-seeking behavior by cholera patients. This is a limitation. In conclusion, the investigation confirmed the existence of a cholera outbreak. It also highlighted the importance and need for comprehensive surveillance, diagnostic vigilance, and prompt medical attention. So it was indeed a re-emerging public health problem. For the public health response measures that were implemented upon the recommendations that were made, wash and food safety training was given to healthcare workers and promoters. Undertakers in affected communities were trained on the management of demised cholera cases. Meetings were held with traditional forum members to discuss cholera prevention and awareness. Clinicians were also trained on having a high index of suspicion for cholera cases, and a weekly multi-sectoral national outbreak response team was activated with various stakeholders for preparedness and readiness. And in areas where cases reside, health promotion was given to family members, neighbors, community members, and leaders, emphasizing safe wash practices and food preparation. One-on-one engagements took place with community members and informal traders, and cholera prevention pamphlets were distributed around the community, and posters were put up in informal shops. These are my references. I would like to acknowledge the following, and thank you very much.
Merci beaucoup. Et nous...
Thank you very much, and we thank Mikobele for her presentation, and she respected the time. We are going to invite Mr. Seth Bafoué. He's going to share with us the schistosomiasis surveillance system evaluation in Aotusenya. Seth Bafoué.
Good morning, everyone. My name is Seth Bafoué, a resident Ghana FETP. Please permit me to present to you the evaluation of schistosomiasis surveillance system in the Aotusenya East in the central region of Ghana. By way of background, schistosomiasis is one of the neglected tropical diseases caused by blood flux, and globally affects about 236 million people from 78 countries annually. About 85% of the cases occur in sub-Saharan Africa, including Ghana, and Aotusenya East in the central region is a known endemic schistosomiasis. About 78 cases were reported in 2021, which account for the need for evaluating the surveillance system to see how it's performing in Aotusenya East. My objective of the surveillance system is to track the incidence of cases in the municipality, that is detecting cases in the municipality, and also to devise an effective way of control and prevention. Again, my demarcated zone in Ghana is an area which has been demarcated for public health actions in smaller sizes. Graphically, Aotusenya the map of Auti Senya showing we collected qualitative and quantitative data and also interviewed stakeholders on surveillance operations using structured questionnaire. We observed surveillance system operation using a checklist and also review and extracted data from consulting room registers for the period and also from the DIMS, that is the data repository in Ghana. We assessed 9 surveillance system attributes, that is simplicity all the way to representativeness. We analyzed the data through frequencies and proportions and computed for data, for quantitative data. Direct content analysis were done for qualitative data, and attributes data collected were scored and ranked in the following order. We obtained permission from Ghana Health Service, and we save all our data in a protected password device. We have no conflict of interest to declare. A total of 21 stakeholders were interviewed on surveillance operation in the Auti Senya East. And also, this is the schistosomiasis information flow. The information flow from the community through the sub-district to the national and our donor partners. And also, there is a feedback from the donor partners and from the national to the community as well. For the period and the evaluation, this is the trend of schistosomiasis cases recorded. Summary of system attributes measured. Simplicity, 95% of the stakeholders, 95% of the stakeholders see the system to very simple. Again, 52% were able to apply the case definition correctly. And 76% were able to know the information flow of the surveillance system. Flexibility, we had 80% being able to adapt to new demands and changes in reporting. And representativeness, all the sub-municipalities submit monthly IDSR reports. Sensitivities over the period, 330 cases were reported, and out of that, 116 were tested. It has a positive predictive value of 92%. In the year under review, an outbreak was detected in 2021, and also the system was able to use the generated data and the outbreak to administer mass drug to school children, that is administer praziquantel to school children in 2021. Schistosomiasis incidence increased in 2021, and this could be due to active case search conducted in the year, which is similar to a study done in Bamako on urban schistosomiasis. We also see increase in cases. With the acceptability of the surveillance system, it was very high. This could also be due to stakeholders' involvement and also community participation in rumor reporting, case detection, and also reporting, which is also consistent with similar evaluation . In conclusion, the schistosomiasis surveillance system meets its set objectives by detecting cases for the period and the evaluation. And also the system is flexible, sensitive, representative, but however, simplicity and stability needs improvement. The surveillance system was useful for the period. Information generated was able to detect cases and also ensure control and preventive measures. We had a high PVP, but I must say that about half of the cases were not tested. We recommended to the Health Directorate, Municipal Health Directorate, to ensure availability of praziquantel for case management. Again, environmental protection of the dam site from school children to avoid whaling and swimming in the suspected dam. And also to integrate schistosomiasis surveillance into other public health programs with fundings so that regular monitoring and supervision can be achieved. By way of public health action, an on-site education was given to nurses and staff on the use of case definition. Again, we leverage on the morning health show to educate the community on prevention and control of schistosomiasis. We also had a community debate to give feedback to the community and also to encourage them to continue reporting rumor and also educate their children against schistosomiasis. We acknowledge the following for making the evaluation process a successful one. Thank you.
Ok, merci à M. Seth pour sa présentation.
Thank you very much, Mr. Serge, for your presentation. We are now going to the next presentation.
Mbizodwa Matalane from South Africa. I will be presenting evaluation of schistosomiasis surveillance system, which was conducted in Ehlanzeni district, Mpumalanga province, between the period of May 2020 to June 2022.
Ici, c'est bloqué.
This is the outline of my presentation. And these are the abbreviations that I will be using throughout the presentation. Schistosomiasis is a neglected tropical disease which is caused by parasitic worms. School-age children are particularly vulnerable to schistosomiasis. The schistosomiasis infection is prevalent in tropical and subtropical areas in poor communities without potable water and adequate sanitation. It affects over 240 million people globally annually. More than 4 million people are infected with schistosomiasis in South Africa. In 2022, Mpumalanga province recorded 2,050 schistosomiasis cases, with 88.6% reported in Ehlanzeni district. Schistosomiasis surveillance system aims to identify at-risk population, monitor the trends of cases, and improve reporting. Schistosomiasis surveillance system is conducted with the aim of identifying the at-risk population and to determine the trends and to improve reporting. So in South Africa, schistosomiasis is a category 2 notifiable medical condition, meaning that it must be reported to relevant authorities within 7 days of diagnosis. So this is the surveillance flow of the schistosomiasis, where patient will consult in the facilities, and when they consult, the specimen will be collected. And after collecting the specimen, it will be sent to laboratory. It's either private or public laboratories, and then the information will be entered into the NMC data mat. Our aim of conducting the study was to assess the usefulness and the attribute of the schistosomiasis surveillance system in Ehlanzeni district, Mpumalanga province, from the period of May 2020 to June 2022, with an objective to assess the usefulness, data quality, acceptability, and simplicity of the schistosomiasis surveillance system, and also to recommend and to make recommendation to improve the surveillance system. We conducted a descriptive cross-sectional study using the CDC updated guidelines for evaluating a surveillance system. The study was conducted in Mpumalanga province, which is situated in the eastern part of South Africa. Ehlanzeni district at over 1 million population in size in 2021. It has 13 hospitals, 124 primary healthcare facilities. The study participants were healthcare workers, which were conveniently selected in 3 healthcare facilities, and we purposefully selected healthcare workers responsible for diagnosing and reporting schistosomiasis. Notification forms were used to collect data and interviews with healthcare professionals. Through interviewer-administered questionnaires, data entry and cleaning analysis was done in the Microsoft Excel in 2016. We calculated proportion of completeness, complete records, and participant responses. We obtained the permission from the district and also from the facility managers. And before the health workers were participating in the interviews, we obtained the consent forms. Under the attributes that were assessed, we assessed usefulness, and we asked the participants what actions they take after receiving the results of the schistosomiasis, and also the interpretation of the data from the surveillance system. Under data quality, proportion and completeness forms and variables were assessed. And under acceptability, we assessed willingness of the participant to continue with the system, and also the completeness of the notification forms. Under simplicity, we assessed the proportion of participants whoever completed the notification forms, and also the time it took for them to complete the notification forms. The demographic data of our participants, majority of the participants were females, with a proportion of 82%, and 77% were aged between the age of 30 to 39 years. High proportion of the participants were registered nurses at 91%. Out of the 22 healthcare workers that were interviewed, 88% did not know why the surveillance data was collected. And 40% of the notification forms were fully completed, and compared to 60% which were incomplete. 32% or date of symptoms of onset seems to be high missing information data on the notification forms. 68% when the participants were asked the following question, if they were trained on cystosomiasis, 68% indicated that they were not trained on cystosomiasis. And when they were asked the preferred method, of reporting, 82% of the participants reported that they preferred paper-based notification. And 68% of the participants indicated that completing a notification form is burdensome and they need further training. In conclusion, the surveillance system was not simple and somewhat not acceptable. This is evident on the time that is spent in completing the notification forms, and the reporting that they completed the notification form is burdensome. And also the incomplete data, it also indicated that the system is not being simple and acceptable. The surveillance system had poor data quality and lacked regular data interpretation. We recommended enhancement of the surveillance data system and also training of the healthcare workers on the completion of the notification forms and the importance of data analysis and use of the cystosomiasis surveillance system. The public action that we took after this assessment, we gave feedback to the facility personnel and also to the facility manager. And we are planning to conduct training for healthcare workers on the importance of surveillance data quality. These are my acknowledgements, and thank you.
Thank you very much, Madame Madalan, for your presentation. We are now going to go into a question and answer session. And you have a chance to ask each presenter the question. So just raise your hand, and then the microphone is going to go around for you to ask your question to any of the presenters. So the presenters, please note your questions and be ready to answer them. The microphone doesn't seem to be working. I am David from the DRC, and I'm asking this question to my South African colleague who has just made a presentation. In her objectives, she said that there were 3 objectives, and one of them was the evaluation of the surveillance system. And then she also adds evaluation of data quality. I don't know what the difference is, or what is the similarity between evaluation of the system, surveillance system, and then evaluation of the data quality. Because in my view, it's the same thing. Data quality would really be part of the surveillance system. Thank you for giving me clarification on that. I would like to congratulate the speakers and about the recommendations from the DRC. When you talk about improving data quality, you mentioned that there's a weakness in quality, and you said that you're going to improve data quality, but we're not sure what exactly is going to be done. So I think this recommendation should be operational and more concrete to show exactly what is going to be done. Because when we put in place a health system, there's a system for data collection, and we should have quality data. So please highlight that. This question is going into Madame Mandala. So another question for the three presenters, please. Thank you very much for giving me the floor. I'm from the Democratic Republic of Congo. I have a concern on the cholera presentation, and this is about the environmental surveillance. How is this organized in South Africa during cholera outbreaks? And then another question is on the recommendations. Is there a specific recommendation on limits on activities for the traditional methods? A question for the presentation on evaluation of schistosomiasis surveillance. So we're going to allow the presenters to answer the questions.
Thank you very much for your questions. So the first question that I got was on the environmental health surveillance and how is it done in South Africa. So environmental health plays a very important role in outbreaks as they collect all the samples, excluding the lab samples from human specimens. So they collect the water samples, food samples, and any domestic drinking water samples. So that is their role in an outbreak investigation. And you spoke about the specific recommendations on limiting activities of the traditional healing population. So they are a hard-to-reach population, and they practice their own activities. So it was quite difficult to engage with them, and that's why we had the meeting with the traditional forum members to inform them of cholera prevention and awareness, and hopefully this would then allow them to go back to the population of traditional healers and also inform them of how to prevent the spread of cholera. I hope that answers it. Thank you.
Thank you for the questions. The first question was the difference. I think all in all, you was asking the difference of the surveillance system and data quality. So the surveillance system is the system that we use to collect information of the clients when they come for consultation or when we have notifiable medical conditions. This is the surveillance system we use. So in that surveillance system, there is information that should be entered into the system. And if that information is not complete, then it will not assist us to respond effectively. So that is why it goes together, the surveillance system and also the data quality, because we need to collect that data quality or quality data in order for us to respond to the outbreaks or to respond to the challenges that we might be facing. And then the surveillance system is, okay, I think the other question was about when talking about quality data, what is it that we meant when, what exactly do we mean? I think this one I responded to. And then the other one was about I forgot, but I wrote it down, but I forgot what is the other question was about. Maybe it can be repeated so that I can respond to that.
It was about the recommendations. It was about the recommendations. We are time constrained, so we just thank you for your responses. We are sorry we cannot continue. And we would like to invite the other three presenters. Thank you very much for this session. And now let's invite the three other presenters to come to the podium. Madame Adujoa We want to invite the following presenters, Mr. Eric Mulangu. I'm sorry for mispronouncing your names. Madame Augusta Aqueno. We are now going to ask Mr. Eric on the Shilegosis outbreak investigation in DRC. Good morning, everybody. I'm Eric Mulango. I come from the DRC. It's my privilege to share with you our work on Shilegosis outbreak investigation in a prison zone Mweneditu Lomami in the Democratic Republic of Congo. Shilegosis is a diarrhea contagious disease with an epidemic potential and is proved to be a public health concern in the Democratic Republic of Congo. In 1994, a terrible outbreak was reported amongst Rwandese refugees, which caused about 20,000 deaths in 1 month. And between 1999 and 2003, other outbreaks were reported in Sierra Leone and the DRC. This case of bleeding diarrhea affects many areas in the Mweneditu zone area. In October 2022, this disease was reported in 22 cases were reported in the DRC within the population of people in the prison area. In this prison. So this led us to investigate this epidemic of bloody diarrhea in the prison quarters in Mweneditu. We had this following objective: determine the scope of the disease, describe the cases in terms of time, place, and person, identify the source of contamination, the factors favoring transmission, collect samples to identify the causal agent, and define control measures. Our study was carried out in a prison quarters within the Mweneditu zone in Lomani province in the Democratic Republic of Congo. In 2022, this had a population of 21,920 inhabitants. This is an urban area with 4 other health zones. There are 5 cells within this area, and one of these is the central prison area. The methodology, we carried out a cross-sectional descriptive study between 24th September to 15th October 2022. Our study population was the population living and working in the central prison. Our case definition of shigellosis is anybody suffering from abdominal pains and diarrhea with blood in the stool, and having gone to the central prison between 24th September to 16th October. We also did literature review. We looked at, document review rather. We looked at different reports, epidemiological weekly reports. We looked at forms for patients and notification cards and interviews with prisoners and people working in the prison. Stool was collected from every suspect case. And we also used Excel 2013 to carry out our analysis. We presented our findings as follows using charts. The daily evolution of death cases. The first case was identified on 24th September 2022. And then you can see the curve moving until 30th September 2022. We had investigations on 3rd October in 2022, which improved case detection before these reached their peak on 5th October 2023. I know that there was a drop. So different interventions for public health were carried out during this period up to the 15th October 2022. Looking at this curve, you see a contamination from different sources. Then the scope of the disease, we looked at the fatality and attack rate, which was observed in the prison cell. And it was more pronounced in the central prison. We had 2.2% fatality rate in this area. And then this is our second map. Most cases came from the prison cell, prison area. And then we had 3 policemen who work in this prison who were also contaminated from this prison cell area. If you look at the distribution of cases, the median age was 27. The ratio men-women was 84:9. Then regarding the status or profession, we had police officials, nurses, administrators, but the highest rate was amongst the prisoners. Distribution of cases regarding lab results, we able to collect these samples and carried out culture, and then we had 25% Escherichia coli. And then we also had, the source of water was water from the wells, 95.7%. We also observed excreta. So now discussion of results. Out of the 93 suspect cases of shigellosis identified, we had the global fatality rate was 2.2% amongst the admitted. These results are close to the data provided by WHO. The median age was 27 years and representing 46.2%. These results are also close to the study carried out by Okome regarding shigellosis in Gabon in 1999, where the median age was 20 to 30 years. The sex ratio was 9.3 and is very different from the study carried out in Gabon. The age group that was most affected by the disease was the one of above 50 years. And this result shows us that people above 50 years are more vulnerable to this disease. Prisoners were the most affected, representing 92.5%. And this result is close or corroborates the one done in Gabon. And then people who consumed water from wells were most affected, 95.7%. Conclusions. Shigellosis outbreaks were confirmed in the central prison of Mweneditu by the presence of Shigella dysenteriae, and then the source of contamination was consumption of well water. Medical management of cases, water treatment, sensitization of prisoners on hygiene practices contributed to the reduction of the mortality of the disease. And so clean supply of water in this prison is very important. The references are provided and some photos to show you the prison conditions in this Mweneditu. I thank you for your attention.
Monsieur Eric pour sa communication.
Thank you, Eric, for your communication. And now we are going to hear the presentation of Grace on schistosomiasis outbreak investigation in Ghana. Thank you.
Good morning, ladies and gentlemen. My name is Shahadu Saibu. I'm a resident of the Ghana FETP, and on behalf of my team, I'm presenting schistosomiasis outbreak in the Eswatini community in Ghana. This will be the outline of our presentation. We'll go through the background all the way through recommendations and public health action. Schistosomiasis is one of the neglected tropical diseases, and worldwide it affects more than 250 million people, usually leaving destructive effects in some of the body systems. The Eswatini community used to be on praziquantel mass drug administration, but was taken off in 2018 following an assessment by a team. However, on January 4th, 2023, a 14-year-old boy was hospitalized in the Cape Coast Teaching Hospital, and this was after he collapsed at home. He had had several episodes of hematuria, which were ignored initially. So he was treated for severe anemia, but further tests revealed that he had urinary schistosomiasis. Upon review of records, there were similar hematuria cases in more than 11 facilities in the community. So we set out with the objectives to determine the magnitude of the outbreak, to determine the source, to describe the characteristics, identify risk factors, as well as implement control and preventive measures. The map here shows the Eswatini community, where it's located in the central region along the coastal part of Ghana. Eswatini is one of the communities, 49 communities, along a river called the Kakum River. We conducted a one-to-one on match case control with descriptive and analytic arms. So for the descriptive part, we interviewed the index case, developed a case definition, following which we conducted case searches. So the case definition for the suspected will be any resident of a sanctuary who developed hematuria or bloody stool, and it would be from 1st October 2022 to 17th April 2023. And a confirmed one will be a suspected case in whom tests revealed that he had schistosoma ova on microscopy. We generated a line list and then drew EpiCurve and a spot map. So for the analysis of the descriptive part, we calculated frequencies, proportions, means, and their standard deviations, and then also attack rates. For the analytical part, we developed a hypothesis, and that was the fact that the Kakum River was a source of infection of schistosomiasis to the residents. Then we recruited cases and controls. So for cases, we recruited those who were, we did both hospital-based and community-based. So we recruited all those who were symptomatic and had presented to the hospital. And then from the community, we searched for cases which were symptoms. And for control, for any particular household where we got a case, we would pick control from the next household. We analyzed the data by using logistic regressions in which we calculated crude odds ratio and adjusted odds ratios at their 95% confidence interval at a p-value of 0.05%. We conducted both environmental risk assessment, within which we assessed for wash facilities, and also we assessed the Kakum River for snails. And then for behavioral risk assessment, we observed residents for their contact behavior with the Esuichiri River. And then also we assessed residents for toilet facilities. And then for the laboratory investigation, we initially examined the urine samples for, actually we used urine sample. We examined for gross hematuria, following which we go on and do microscopy. And for the controls who did not have gross hematuria, we went on to do urine dipstick so that we could then test on microscopy for those who were positive. Figure 3 shows the EpiCurve, and it depicts a propagated source of infection. Our overall attack rates were 6%. And then of the 118 suspected cases, 94% were confirmed to have schistosomiasis by microscopy. The mean age was 12 years for individuals who were affected. Males represented 78%, whereas school-age children in general accounted for 86% of all the cases. When it comes to exposure, behaviors like swimming, fishing, and drawing of water were each associated with increased odds of schistosoma infection. During our observation, which we did for just 1 hour, we observed 66 residents to have come into different contacts with the river. Some were drawing water, but the majority were young boys who were swimming. When we look at figure 5, we look at the source of water for utility at home. We can see that almost 70% of the residents drew water from the river for utility. And then figure 6 shows us the toilet facilities, in which over 60% practice open defecation. In figure 7, we see the schistosoma ova on microscopy. And then figure 8 shows us the 2 samples of snails that we retrieved from the river. In our discussion, we said that our attack rates were lower than the 10% found, the 10% and 35% found by other investigators. And the majority of cases were school-age children, and of course, male school-age children. And this may be due to the fact that male children usually take more risk in wading into the river, and we found that in our observation. We concluded that the proportion of Esuichiri residents who had overt hematuria and went on to test for schistosomiasis was low. Male children were particularly affected, and then the Kakum River was the most likely exposure source. We recommended resumption or continuation of mass drug administration because we conducted one to begin with. And then we also recommended sensitization to health workers and to the community in particular. For our public health action, we are seeing on the left side directly administering mass drug administration, which is praziquantel. And then also on the right, we are seeing conducting community debates and engaging community leaders. We acknowledge the following for their support in our study. This will be our references. Thank you very much.
OK, donc nous remercions Monsieur.
We thank Grace for his communication. Now we are going to follow the last presentation on the epidemiological profile of data for neonates deaths between 2018 and 2021 in Weme department in Benin. Thank you. Good morning, ladies and gentlemen. Augusta. I want to present the study titled Epidemiological Profile of neonates deaths in Benin. So this is my outline. After the introduction, I'm going to talk about the methodology and the findings and the discussion. We know neonate mortality is the number of children who were born living but die before 28th day. This is a public health issue. The WHO said that 47% under 5 are neonates who die, and around 2.4 million children die before reaching 1 month of age. In the same year, Africa registered 27 out of 1,000 living babies, and Benin registered 30% for 30, actually 3%. And in Weme, 1.44% in the, and with this situation, we try to analyze the database of neonate deaths in Weme. Now, what are the objectives of our study? In general, we described the epidemiological profile of neonates deaths in Weme. And specifically, we described the neonates deaths in the department. We estimate the neonate mortality in the department, and we made a few recommendations. Now, for our study is on Weme, and this Weme is made of 9 communes. It is in the north. So this is actually the map of Weme. So we carried out a cross-cutting descriptive study from July to September 2022. And the population under study is made of neonates who died from 2028 to 2021, and they were registered in the database. The data from this database had been analyzed using AP-Info 7 software. Ladies and gentlemen, what are the findings we came up with? Overall, 1,815 neonates were dead in that department. And between 0 and 7 days, we have most affected. That is, most of them are males, and most of the neonates who died had a lower weight, a weight lower than 2,500 grams. On this chart, you can see the evolution of the neonate mortality in the department. We realize that in this chart, in 2021, we registered less than 10 neonates dead out of 1,000 living births. And the ratio is more than 10 in other years. The figure here shows us the causes of neonates deaths in the department. We can realize that, we can see that prematurity was one of the major causes of the deaths, and asphyxia and infections. On this figure, you can see the distribution of neonate deaths based on the residence, the commune of residence. On this figure, you can see that apart from UMA communes, a major part of neonates resided in communes of the neighboring departments, such as the so now, in our study, we realized that there is a result based on the age, the median age, 4.25 days with a deviation of 5. Kadia Tuture made the same observations like us. However, Nagalo et al. Found different results regarding the weight. We found that 68% Kalonji found the same findings just as in our study. However, Rafama found a different result. Now, for mortality, we found a result of 11.67 per 1,000 living births, and Rafama found the same, but Zungra found a different result. For the causes of death, we have the same result as Barrow. Our results are different from Rafama's results. To conclude, the neonatal mortality is still high in women, and the majority of the deaths was with low late at birth, and the major causes were prematurity, asphyxia, and infections. However, taking into account all those causes would contribute in the reduction of that mortality. So we are going to make a few recommendations. We recommend to the different stakeholders, that is gynecologists, to ensure an adequate antenatal monitoring for pregnant women, and to make sure that there's a good surveillance of travail for delivering, and to make a good monitoring for the premature, and especially for those who are suffering from asphyxia for the neonates. We also recommend to the actors of epidemiological surveillance to strengthen epidemiological surveillance for neonate deaths, and to achieve audits for all the neonates deaths. These are a few references for our study. We thank all that helped us to carry out this study. Thank you.
Merci beaucoup à Madame Augusta pour ça.
Thank you, Madame Augusta, for your presentation. So now we are going to start with the Q&A session. We are going to have questions for each presenter. So we delayed. So you have your microphone.
La troisième personne.
Third person. Good morning, everybody. Thank you for your presentations. I have observations for Eric. In your presentation, you say that the population of Mwini D2 was 2021, and the density is the same. I think you need to check again. I think that was maybe a mistake. Then the epidemiological curve, instead of being linear, it is linear. I think you need to correct that. For Mr. Grace, let me put it in English.
Did recommend MDA, but when you did your environmental assessment, you discover snail in the river. So what did you do about it? Augusta. Vous avez fait le
You did an epidemiological profile, and you described per person the causes, but you forgot to describe per period of time, because the majority of the deaths are for children under 7 days. So I think you need to deepen your analysis. You need to tell us what is the period. What is the period of time, or the period of the week when those deaths occurred mostly? Because in regards with the reports that we got from pediatricians, from the reports of the pediatricians, they said that most of the deaths occur during the weekend when there is no specialist. So may you review that and show us it is the same in your study, so that we can make appropriate recommendations for the community. Thank you. So you can see that the three presenters have already a question. So let them respond. For other questions, maybe you can continue even later. Thank you. Thank you for the interest that you showed for our work. In regards with your observations regarding the density, the population that was presented is the population it is in a prison. It's a prison where of less than 1 square kilometer. So the density is the same. So we are going to review and correct accordingly. Thank you.
Thank you very much for your interest in my presentation and also for the question. I agree with you. It's an oversight that the issue of the snails did not come out in our presentation. But if you notice our public health action, you would have seen us speaking to stakeholders as well. So in the past, there used to be programs for molluscicide, whereby snails used to be rivers used to be treated so that snails will be reduced. We discussed this with the municipal chief executive, who is the political representation in the district where the community is located. So they also assured us that they will activate the system and go through, because it's quite a logistic, it's resource intensive. So it is something that is being worked on right now. So that is how far I can explain. It is not something that our resources would have allowed us to do at the time, but we went on discussions in that tangent. So it is something that hopefully will be conducted quite soon. I hope I've answered your question.
Merci. Merci pour les apports de notre travail.
Thank you for your question regarding the period of time of deaths when they occurred. We can say that in 2019 there were more deaths in the department. Now, regarding the week, it is every single day we had deaths that occurred. So precisely, we carried out our study based on the years. We did not distribute based on the weeks. Thank you.
Ok, mesdames et messieurs, nous sommes.
Ladies and gentlemen, we are concluding our session. You can see that we are sorry for those who are not able to ask questions. You can continue to discuss with the presenters, and we thank you for the interest that you actually showed for these different topics. Thank you very much. We are concluding this session.
Mesdames et messieurs, honorable
Ladies and gentlemen, dear friends, good morning. Good morning, everybody. It's a great pleasure and honor to be with you this morning as the moderator of this session. We had 11 presentations scheduled for this morning, but 2 are absent. The first 5 presentations will be made, followed by question and answers. Then we shall move to the next group. So I'm going to ask the 5 first presenters to come to the podium to come and make their presentations. That includes Veronica. Please come to the podium. Joseph Sam, come as well. We also have Harry. Shaban, are you there? Can you come as well as Yannick? So out of these 5 first presentations, we are going to have 5 minutes for each presenter so that we can catch up on time. And then we have the question and answer session at the end. So Veronica, you have the floor.
Ok, vous avez 5 minutes.
Yes, good morning, everyone. Bonjour. My name is Veronica Kembabazi from Uganda. I'd like to make my presentation on a study to assess the compliance to tuberculosis and HIV integrated standards of care through clinical audits at referral hospitals in Uganda. The continuous monitoring of TB-HIV standards of care at facilities enhances the quality of TB-HIV care. And between 2008-9 and 2015-16, we witnessed an over 60% increase in antiretroviral therapy uptake. And during the same time, we saw screening of TB increase by almost 70% in the facilities. However, patients continued to die. TB-HIV co-infected patients continued to die in significant numbers. The Uganda Ministry of Health by 2020 had been implementing integrated TB-HIV care at art clinics for over 10 years, and little was known about the performance of those facilities in this care. We therefore assessed compliance to the standards of integrated TB-HIV care at regional hospitals in Uganda. So how did we go about this? We conducted clinical audits between July and August 2020 at 15 regional referral hospitals around Uganda. We went ahead to assess the files of TB-HIV co-infected patients who were diagnosed between January and December 2019. We used the lot quality assurance sampling method for sampling and also for auditing the files. So as you can see from this table down below is the lot quality assurance sampling decision table for sampling and analysis. This method was originally designed for quality assurance in industries to assess the standards in delivering a service. So it has been adopted for use also to assess standards of health service delivery at facilities. And it indicates the sample size that you can use for the supervision areas that you want to audit, the sample size, that is the number of units that you're going to audit, and also it gives you the cutoff points, that is the minimum number of units that you'll assess that will give you your target for compliance. So the Ministry of Health set a target of 80%, which meant that 13 out of 19 facilities, 19 regional hospitals, should have achieved 100% of the
technologies to support health and health-related fields like health surveillance, education, knowledge, and research. Globally, the World Health Organization came up with a strategy on digital health 2020-2025, and there's been an increase in the adoption of e-health. In Africa, adoption varies due to the differences in technology infrastructure and different challenges that are contextual. In Uganda, the National e-health strategy was adopted by the Ministry of Health, and we've seen a growing e-health sector. Uganda has adopted various e-health tools like the DHIS2, mHealth, the Uganda EMR, and so on. How population included the e-health users in the different NGOs. We sampled 108 health workers using simple random sampling, and for the qualitative, we use purposive sampling. Reporting odds ratios. For qualitative, we did thematic analysis supported by Atlas TI version 7. We found that only 4 out of 9 NGOs are using e-health at community level, and most tools were being used at facility level. 45.5% of our participants reported non-consistent use, and the greatest challenges were due to network issues. The different systems and tools used included the Uganda EMR, and the KP Tracker, CHAM, which is Client Health Administrative Management Portal, ISEA, and looking at our different the factors found and tools used include associated the Uganda EMR at multivariable level were interoperability and systems enabling data accuracy. The challenges included limited technology infrastructure, and looking at from technical teams and the human resource gap. We conclude that the Uganda Ministry of Health adopts systems that are that allow for interoperability and work offline, avail the technology infrastructure, and do different refresher trainings. We acknowledge the following. Thank you.
Merci Isabella Kiza pour la qualité.
Thank you, Isabella, for the quality of your presentation. We call David Gitao, who's going to talk about the characterization of cases of adult HIV in Maragua Sub-County Hospital, Murang'a County in Kenya.
Ok, Monsieur David, vous avez 5 minutes.
You have 5 minutes. Okay.
Thank you. My name is David Gitao, FELTEP Kenya intermediate graduate, and I'll be presenting to you a study on characterization of HIV positive cases in Maragua. Yeah, characterization of HIV positive cases in Maragua Sub-County Hospital, which is in Murang'a County, which is in Kenya, in 2021. So by way of introduction, HIV and AIDS pandemic remains a global public health challenge, especially in sub-Saharan Africa, with Kenya ranked 7th globally in terms of HIV and AIDS burden. So HTS, or HIV testing services, is the gateway to care and treatment services. And so for us to achieve the HIV epidemic control by the year 2030, we all need to meet the UNAIDS 95 targets, which are set globally. So Kenya, as a country, our identification rate is at 86%, and Mwangea is at 85%. So HIV case identification remains a key challenge to epidemic control. And so in this study, we sought to describe the social demographic and clinical characteristics of the HIV cases. In terms of methods, the study site was at Mwangea Sub-County Hospital, which is the largest HIV clinic in the county, with about 10 counselors offering HIV testing services. So we reviewed records from the HIV testing and leakage registers in 2021 for all the cases that were recorded in that year. The data that was collected was entered into a spreadsheet, and data was analyzed using MS Excel. In terms of results, what we saw is that the mean age of the cases was 40 years, plus or minus 14 years, and about 40% of them were aged 35 to 46 years. Women accounted for 59% of the cases. And then in terms of marital status, 66% of the cases were actually married monogamous, meaning they were only married to one spouse. In terms of TB screening outcomes, 29% of the cases had presumptive TB, and 14% of the cases were in a serodiscordant relationship, and 54% of the cases were first-time testers. 18% of the cases were not linked to care and treatment services. So these findings disagree with a report by National AIDS Control Council that 42% of the new HIV infections occur among young people, but also agree with the report that more women than men are actually HIV positive, identified as HIV positive. The finding that half of the cases were first-time testers indicates there are a lot of unreached people with HIV testing services. And most of the cases were married monogamous. Was also an interesting finding for us because we attribute this to these cases having multiple sexual partners. A third presumptive TB, confirming that TB is the most common opportunistic infection. 14% of the couples were in a discordant relationship, and so there's need for partner testing. And the majority of the cases were identified, but then again, the below recommended rate of 90%. In conclusion, we found that most of the cases identified were actually married people, and women contract HIV more than men, and discordancy, HIV discordancy and TB are prevalent among the cases. In terms of recommendations, we recommend that there's need to tailor-make HIV prevention strategies like PrEP for married adults, and there's need to target women more in HIV testing, and there's need to create awareness for HIV discordancy, and also encourage partner testing, couple testing, and that all HTS providers should test all TB patients for HIV. We're also able to disseminate these findings to the county HIV and prevention TWG. Thank you.
Merci, David, pour la qualité.
Thank you, David, for the quality of your presentations. Ana Sofia Pinheiro from Angola. She's going to present monitoring and improving turnaround time of HIV molecular testing in Angola.
Vous avez la parole.
You have the floor. Bonjour, Je m'appelle Anya Peñola, je suis coordinateur du projet du AFENET en Angola. Aujourd'hui, je vais vous présenter je vais vous parler donc du suivi et d'amélioration du suivi. Je vais parler en portugais et je...
AFENET is one of the implementing partners of CDC in Angola for laboratory activities since 2012 to improve the capacity of public health laboratories to provide health services, especially to improve HIV diagnosis through PEPFAR funding. And aligned with national priorities, AFENET has been supporting selected clinical sites in 4 provinces to expand access to viral load testing in early infant diagnosis. VL testing is a virological indicator to monitor the efficacy of antiretroviral treatment, identify cases of therapeutic failure. Angola is giving its first steps in the testing at the point of care, and the majority of tests up to now are carried out in high-flux equipment in centralized laboratories. Therefore, service providers collect samples, and these samples are taken to referral laboratories by car, and the results often are returned to the clinical sites in the same way. The faster turnaround of these results has an impact in clinical decisions. And to improve this, AFENET has been tracking the transmissions of these results back to the clinics by monitoring the missing results and monitoring the turnaround time. For these studies, I will present the results of the activities in healthcare providers in Benguela, Huambo, and Kunene that had been trained in the supervision and sample collections and referral at the Benguela Regional Laboratory. Samples and results information was inserted into logbooks at the sites by laboratory technicians. AFENET mentors have been carrying out periodic reviews of logbooks and uploading data into an online tool that allow the tracking of missing results and tracking the turnaround time by the laboratories. This between the sample collection data and the return of the results to the clinics. In order to decrease the turnaround time, AFENET has conducted targeted corrective actions as needed. The results, after 1 year, show that within the first year of work, in October 2021, the percentage of missing results was 9%. In September 2022, this year, there was a reduction in the number of results missing. Also, the average turnaround time of results improved. In Benguela, you can see it in yellow, has reduced from 46 to 18 days, as you can see. In Huambo, the turnaround time decreased from 53 to 26 days. And in Kunene, as you can see in blue, the turnaround time decreased from 39 to 31 days. Within the period in analysis, the referral laboratory had to interrupt services due to lack of testing equipment, and as you can see, it affected the turnaround time in December, February, and April. However, you can see that the reduction of missing results and turnaround time may be explained by some of the good practices introduced by AFENET mentors. In general, this study was an innovative approach to monitor and assess the system, and in this way help reduce the turnaround time in laboratories. Thank you very much for your attention.
Merci Anna Sophia pour la présentation.
Thank you, Anna Sophia, for your presentation. Then the last but one presentation of our session we call George Mrema. George Mrema, I hope I have well pronounced your name. He's going to talk about the survival and predictors of mortality among multi-drug resistant tuberculosis after decentralization of services in Tanzania.
Good morning. I'm sorry, I'm almost half the height, the same as this podium. My name is George Mrema from Tanzania, FLTP resident, advanced course. And I'm going to present to you my research titled Survival and Predictors of Mortality Among Multi-Drug Resistant Tuberculosis Patients After Decentralization of Services in Tanzania from 2017 to 2019. So we know that multi-drug resistant tuberculosis remains to be a disease of public health importance, and there is a concern with the treatment outcome of this patient globally, and most of the times it's contributed by high mortality. For instance, for the year 2020, there were more than 150 cases that were diagnosed, new cases, and out of this, only 59 were treated successful. That means we remain with 41% who were not treated successfully and contributed highly by mortality. Previous study have indicated that mortality to range between 4 and 31 across different studies. And the World Health Organization made several recommendations to improve this outcome, including decentralization, to recommend decentralization of services, and also formulation of guidelines to assist in management of these patients. However, following decentralization, there have been different outcomes in different countries and different contexts, which warrant now the aim for us to conduct this study, where in Tanzania we decentralized the services in 2016. However, following this decentralization, there has been an increase in mortality, proportions of death from 12% in 2017 to 19% in 2019. Sorry, it doesn't appear there. So we aimed to assess survival and predictors of mortality among multi-drug resistant tuberculosis patients. So this was a retrospective cohort study, which involved 31 regions in Tanzania, and we included all patients who enrolled into treatment between 2017 to 2019, and we estimated the mortality rate using incidence rate and survival probability using Kaplan-Meier estimator, and we determined predictors of mortality using multivariable Cox proportional hazard model. The study followed a total of 985 patients for a period of 12,938 person month, and we found a crude mortality rate of 11.83 per 1,000 person month, and specific mortality rate, we in follow-up time, we are at 6 months, it was high at 17.2, and lower at the end, which was here 6. And we found that patients who were HIV positive, MDR-TB HIV co-infected, to have lower survival probability, as you could appreciate in the survival curve, and similarly those with malnutrition to have lower survival probability. And among the predictors, we are seeing that patients who were malnourished, they had 2.9 hazard of dying as compared to those who were normal. And similar, those who were HIV positive to have 1.9 hazard of dying compared to those who were normal. So we see that following decentralization, there is high mortality rate within the first 6 months of treatment, and there is low survival probability among patients who are HIV positive and those with malnutrition, and significant predictors of mortality were found to be malnutrition in MDR-TB HIV co-infection. To reduce mortality, we recommend that for patients to be followed very closely, especially during the first 6 months of treatment, and we provide them with the appropriate and appropriate care, especially for those patients who are HIV co-infected and those with malnutrition. I acknowledge the United States President Emergency Plan for AIDS Relief, PEPFAR, through CDC for funding this study, and also Tanzania FELTEP and Muhimbili University and Tanzania National TB and Leprosy Program. Thank you.
Thank you very much, George, for that high-quality presentation. We are now going to listen to the last presentation of this session. We're now going to ask Samuel, who is going to talk about evaluation of multi-drug resistance tuberculosis in Sierra Leone. You have the floor.
Ok, Monsieur Samuel, vous avez 5 minutes.
Good morning. My name is Samuel Saubilo from Sierra Leone. FETP, an FETP intermediate graduate. My study I'm going to present this morning is evaluation of multi-drug resistance tuberculosis surveillance system in Sierra Leone from 2020 to 2022. Multi-drug resistance tuberculosis, MDR in short, a complex infectious disease that has posed threats to global health, including Sierra Leone. Globally, an estimated 630,000 patients have multi-drug resistance at any one point in time. Sierra Leone is estimated that incidence of 8.2 per 100,000 population should be notified each year. The tuberculosis surveillance system is part of the general framework of the integrated surveillance system and response, but there are no documented records showing multi-drug resistance system evaluation in Sierra Leone as of date. We evaluated the system to determine its performance, assess its key attributes, and make appropriate recommendations to improve the system. This one, you can see the machines that we normally use to diagnose MDR, which is a gene expert machine. A descriptive cross-sectional study was carried out in all 4 treatment sites providing gene expert tests. We use the US CDC updated guidelines for evaluating public health surveillance systems. Participants were interviewed based on their involvement with multi-drug resistant tuberculosis surveillance activities. Data were extracted from treatment and laboratory registers from 2020 to 2022. Content analysis was performed on the responses of key informants and data analysis using MS Excel. You see the map of the centers. These are where the treatment centers are cornered, one of the district, Bombali, and Western area. Western area is divided into 2 sections, urban and rural. Ladies and gentlemen, I now present the results of our findings. The system was useful in detecting
MDR, in detecting 299 MDR TB cases from 2020 to 2022. The representatives of the system was rated at 14.4% health facilities nationwide. The system was found to be simple at 97.5%. Proportion of new testing machines and the MDR case definition achieved a flexibility of 94.5%. The system is not stable as it operates at 80% donor dependent. Timeliness was collection of sputum to confirm results was within 48 to 72 hours. In my conclusion, Sierra Leone MDR surveillance system is useful in meeting its objectives. The attributes of the systems we have found to be simple, flexible, but less stable as it's largely donor dependent. We therefore recommend that the Ministry of Health integrate private facilities MDR surveillance activities. My public health action. The results for the evaluation were submitted to the NLTCP, that is the National Leprosy and Tuberculosis Control Program, to aid its decision making. We did radio discussions and community sensitization on health promotion to community on the use of TB multi-drug resistance services to improve on case notification, supportive supervision and mentoring. We are giving the facility staff. Then, my take-home message is multi-drug resistance surveillance system is useful, but it needs donor-driven. I therefore acknowledge the following. Thank you.
Merci Samuel pour la qualité de la
Thank you very much, Samuel, for a rich presentation. We have had an interesting session on neglected tropical diseases, and now we are going to have a Q&A session. We shall have about 10 minutes for this session so that you can ask questions to the presenters. Because we are running against the clock, I will request you to be very concise because we are running behind schedule. Thank you. We already have 2 questions. And we just have 10 minutes in which to complete this session. Okay, let's start with these 2, and presenters take notes, and then you'll be able to answer questions later.
Good morning, everyone, and thank you, our presenters, for your very wonderful presentations. Quite very interesting. My question goes for the first person, David. You know, I love the presentation. That's why I'm here, because I've gone around the hall. David, I want to know how you got your estimated 2022 number of HIV when you are doing your citation. You mentioned it in the introduction and also in the discussion. So I don't know how you got that number, because I know by 2022 we must actually have a data to present, even from the Ministry of Health. And also, another one is to the software. I want to know the public action that was taken and also recommendation. So it's actually it will help me to understand very well, to flow. Then about I want to know the objective of the study and also public action that was taken. Then the last but not the least, Samuel, I commend your public health action. I think it's one of the best I actually have listened so far today. So I also would like to know the objective of the study, because the objective always help us understand very well when presentations are being made, so that we flow very easily. These are my questions. Thank you. Over.
Merci. Il y a un autre candidat pour les questions. La dame.
Yes, the lady, you can ask your question. Okay.
My name is Grace from Kenya. I really want to commend all the presenters. You did an excellent job. I specifically want to commend George from Tanzania. I loved your presentation, and specifically how you presented your results. It was very well done. I have a question on your public health action. I think for a long time we've known that malnutrition and TB contribute to the unfavorable outcome. And so I want to know, because I know that there are systems that are already in place. Have there been any specific public health actions that have been done because of the findings of your study? And then I also want to ask a question to the presenter from Sierra Leone. Your presentation was also very good, and we got a feeling of your surveillance system. My question on the usefulness of your system, I think you told us that you were able to identify 299 cases of multi-drug resistance, but against what target, so that we can be able to grade that usefulness. Thank you very much.
Et allez-y.
Okay. Merci pour la parole.
Thank you for giving me the floor. I'm Christian from the DRC HIV program. I would like to ask my question regarding the samples in Angola. What are the major challenges regarding transport of samples from the time of collection to examination in the labs? And then you're talking about abandoning collections on the paper BBS and going to PSP. Do you have any experiences that you can share in this regard with this strategy that you can share with other countries?
Thank you all the presenters. Fantastic presentation as always. My question, clarification, goes to my brother from Sierra Leone. I think it's even a follow-up to what somebody had observed earlier. Looking at how important multi-drug resistant TB is, is it possible for you to look at the sensitivity, predictive value positive, those are the attributes of the system? Thank you.
Merci. Donc, je pense qu'on va arrêter la session vu qu'on est déjà.
So we are going to stop there because of time constraints. Let us allow the presenters to respond.
Thank you very much.
Listeners and those especially who ask these wonderful questions. That shows how important this topic is and how you were listening attentively. Yes, for the objective of my study is one of the key objectives, I can generalize it, is to really assess using the CDC guidelines in terms of stability, completeness, and all the other attributes, to assess those attributes, whether our system is following those attributes and we are meeting those targets. Then also for the usefulness I got from my sister, yes, the system we said was useful simply because it's whenever we send cases, we try to get the samples based on the signs and symptoms of the disease. We send it to the lab. We have a machine that the processes in going through all these labs is very easy to go through, and we can easily diagnose those patients without any hindrance. And more for the targets. The target is actually by WHO, it gives us a yearly target of 600 and it's always about 640. But there are issues around that because we've not ever done any prevalence study on multi-drug resistance in our country. So we are always battling with WHO targets. We always raise the issue. We have not these targets for the past 4 to 5 years. We've not met this target. How can we do a prevalence study of MDR? But as far as we are concerned, we believe the study is actually useful for us, but we are now working with our funders and WHO to do a prevalence study on multi-drug resistance tuberculosis. For the predictive and sensitivity, it was done. It's just because maybe of time. But I can tell you the predictive value was got 100 because since we are using an automated machine to diagnose RR resistance, because it's purely RR resistance, that is the gene expert machine I showed, it's once the patients are picked on the signs and symptoms, it always gives you the RR resistance. So the positive predictive value is always 100, and it is in my report. It's because of if you can go through, and even on my slide. Sensitivity is a challenge in our country because as I projected the sites where these treatment sites are, it's only 3 treatment sites we have currently in country functioning, but these treatment sites are far off. Sometimes we find it very difficult for patients to move to those sites. And even the diagnosis for patients to move sputum, to transport sputum, we are only now trying to intensify our sputum transportation so that we can transport all samples to those sites. So the sensitivity is a bit low. If you look on my report, it's low, 24.9, if I know very well. So that is why. But sensitivity and positive predictive values were also mentioned. It's in the report. Thank you.
Merci. OK, on peut passer à la prochaine réponse.
Let's go to the next response.
As ações de saúde pública.
These practices have been used by the Ministry of Health, and especially in these units or centers that we work. These helped us to have a direct impact in the clinics when the patients receive treatment. We have the treatment care, especially with HIV and diagnosis with among the children. For the second question, in transport, I think I did not get well the question. We have challenges with transport, especially these units with to go to the labs. This was financed by PFER, and there are more challenges, including the frequency of transport to the Kunene and the Uwambo. It's an answer that is below 15 days. Thank you very much.
Thank you for the question from the lady from, I think, from Kenya. I appreciate you commending my presentation. I almost cried, I swear. So I have 3 responses for you. The first one was the trying to respond to you, the public health action in place. So the first one is the country has established their collaborative TB HIV service provision. So these patients are treated under one roof. We say under one roof because when they go to the hospital, they'll be treated in the same point to avoid this movement in the hospital and to facilitate their timely and early initiation of treatment. And again, we are also providing support for nutritional support, having those plumping nuts and the other nutritional support for those patients with malnutrition. However, they can't went further and providing now the social support. They're providing monthly allowance for those patients with MDR-TB so that they will be able to support themselves because majority of them, they are coming from very low socioeconomic community. And again, we are working on trying to improve timely initiation of treatment because this is the issue here with the decentralization, because there is delay in initiation of treatment due to lack of baseline investigations that are supposed to be conducted before you initiate treatment. So this, the decentralized sites are now equipped with laboratory investigations and other equipment which will be supporting the timely initiation of treatment and avoid delays. Thank you.
Okay, thank you very much for the question. There's a brother who asked a question around the national HIV estimates that I had mentioned in my presentation. These are national HIV estimates that we received from the Ministry of Health, Kenya, regarding the estimated or the estimates in the HIV program. And I want to believe all of us here, I mean every country represented here, normally have these estimates because the estimates are actually given to us through the UNAIDS, the United Nations Joint Program on AIDS. And these estimates are actually derived through a modeling process. There are several softwares used in the estimation of these, in the coming up of with these estimates. And we receive these estimates on an annual basis. So the ones I mentioned were for the year 2022. But again, even for this year, we have the current estimates of 2023. So it's usually a modeling process, usually supported by UNAIDS. Thank you.
Ok, encore merci à tous pour les questions.
Thank you very much for these questions. I want to congratulate all the presenters for their quality and relevant presentations regarding tuberculosis, multi-resistant tuberculosis, and HIV/AIDS. We have come to the end of our third session. I would like to thank you for your interest. Thank you for attending. Please do not forget to scan your badge as you go out of this session. That will help us to evaluate today's session. Allow me to also thank Dr. Peter and Dr. Finuso, our moderators for today. Thank you, everybody, and congratulations to the presenters for the quality. We are sorry that we did not give you more time to ask questions because we are running behind schedule. There's another session on the World Health Security. So we're going to now allow the presenters to take a photo before we close. Let's applaud them once again. Thank you.
Encore merci à tout le monde.
Thank you very much. Enjoy the tea break.